Hi, I am Dr. Felice Gersh, your Integrative OBGYN physician. Today, to talk with you about hormone therapy in women who've had a hysterectomy. I get questions all the time about hysterectomy, and of course, I see many patients who come in and have had a hysterectomy. But what I have found, and I've now learned that many other doctors have the same experience, and it's actually quite distressing, is that the patients don't know what a hysterectomy is. They don't know the language, and they actually don't know for sure what was removed at the time of their surgery. They often don't know the pathology either. So let's just talk about the vocabulary surrounding hysterectomy. So hyster is the Greek word for uterus, and ectomy means to remove. So the word hysterectomy means removal of a uterus, okay? So hyster, uterus, ectomy, remove. It has nothing to do with fallopian tubes or the ovaries. Now, interestingly, there is a separate terminology used for if you remove the top part of the uterus and the bottom part of the uterus, whether the bottom part is removed with the top part or left behind. So, what am I talking about? The bottom part is the cervix. The cervix is in a continuum with the uterus. So, if you think of a light bulb, a traditional old light bulb, if you think of the part that you screw in, okay, to the receiver part of the lamp, that part of the light bulb would be like the cervix. It's like the stem, okay? And the bulb part of a light bulb would be like the uterus. Technically, it's all part of the uterus. So if you remove both the cervix and the top part of the uterus, which is the most common type of hysterectomy, that is called a total hysterectomy. Notice no tubes or ovaries involved at all, just the cervix and the uterus, the top part. Now, what if the cervix is left behind? There was a brief time when that was quite popular, and that is called a partial or subtotal hysterectomy. Now, why would we leave the cervix behind? Well, that's the most common thing that's done if you have an emergency hysterectomy in someone who's just had a baby. Like, say, they're hemorrhaging at a C-section, or they're just hemorrhaging due to atony. The uterus is not contracting. This doesn't happen, fortunately. Very, very rarely does this happen. In fact, in my entire career, when I did obstetrics for 25 years, all types of patients, very high-risk patients, gestational diabetics, hypertensive, preeclamptics, patients with triplets. Okay, I never actually ever had to do a hysterectomy because we do have ways to control bleeding, but it can happen. I'm not saying it never happens. It's just fortunately very rare. It is an emergency like that. Typically, the cervix, which is hard to actually remove when someone's just had a baby, is just left behind. Also, there was a time when we thought, maybe this will come around again, but we thought maybe women would have better support of the vagina or better sexual function if the cervix was left behind. That has actually not borne out, but it may change. I'm always open to new data as it comes. And also, what else could happen if you leave the cervix behind? Sometimes a portion of the uterine lining, called the endometrium, actually extends down into the cervical canal. So when we left the cervix behind, we would do like what we called a coring, where we would actually cut around inside the cervix to take out a lot of the lining, going down deep, because we didn't want what? We didn't want ongoing bleeding. Because if you have no uterus, the top part, but you still have a cervix and then you have bleeding, we don't know what's going on. It's not easy to check on. So we don't want that. But sometimes, even then, there would still be some uterine lining tissue left behind, and then they would have bleeding. Then they would have to have a separate procedure, sometimes called a trachelectomy, which is just removal of the cervix. And also you have to have a pap smear ongoing if you have a cervix left behind, because you can still get cervical cancer. So that kind of went by the wayside pretty much. And now when a person has their uterus removed, which fortunately is not as common as it used to be, it would be that you would take out the cervix with the uterus. And yes, hysterectomy is an extremely common procedure. In fact, way back in the day when I was learning anatomy in the gross anatomy lab in medical school, and we had generous people who donated their bodies to us for us medical students to learn on, there were hardly any women who still had a uterus for us to learn the anatomy from because they'd all had hysterectomies. I think we had two that didn't have a hysterectomy. I can tell you my mom had a hysterectomy, which really didn't have to happen. And I even questioned it at the time. I was not in medical school yet when it happened. And my mother-in-law had a hysterectomy. It's not even clear why. So in the day, sometimes women had a hysterectomy as birth control. Okay, so in any case, a lot of hysterectomies have been done, sometimes for good, sometimes for no reason, or very minimal or unsubstantiated reason. The bottom line is when you have a uterus and cervix removed, that is, remember this, a total hysterectomy. Now, what about the tubes and ovaries? Well, the tubes are the Salpinges, and the ovaries would be OO for ova, okay? So if you take out the ovaries, that's an oophorectomy. Sometimes in animals they call it an ovarectomy, but we usually say oophorectomy. And to remove the tubes, it's a salpingectomy. So if you take out the whole uterus with the cervix, both fallopian tubes and both ovaries, what procedure was done? A total hysterectomy with bilateral salpingo oophorectomy. Okay, so bilateral salpingo oophorectomy means you took out both tubes and ovaries. If you took out only one, then you would say it was the right side. A right salpingo oophorectomy, the left side, a left salpingo oophorectomy. Nowadays, when the uterus is removed, typically both fallopian tubes would be removed. Why is that? We now believe that ovarian cancer most commonly, not 100%, not if it's involving the eggs, like we call them germ cell tumors. Those obviously start in the ovaries. They're involving the eggs, that part of the ovary. But the other types of ovarian cancer, the serous carcinomas, mucinous carcinomas, and so on, those are typically believed to be now originating in the fallopian tube, and it gets transferred, the cancer cells from the fallopian tube into the ovary. So by removing the tubes, you lower the risk of ovarian cancer, which, by the way, is considered a rare cancer. A woman who has her tubes and ovaries removed will have a much reduced, obviously, risk of ovarian cancer. But if they're removed prior to menopause, well, she would have a 35 times higher risk of dying from cardiovascular disease, a heart attack or a stroke, and that is a very big deal. Should also have at least a 300% higher risk of dying from an osteoporotic fracture. So we don't want to remove, unless it's absolutely necessary, the ovaries prior to menopause. And now it's believed that you incur a higher mortality if the ovaries are removed prior to the age of 65. Of course, that's based on what? Not getting hormones back. So we actually don't have data on what mortality would be if you had your ovaries removed at any age, if you actually had physiologic hormone therapy. That said, we really want to conserve our ovaries if at all possible. So enough about hysterectomy. It matters when you give hormone therapy to have some idea of what happened with the uterus, because you just want to know, are you going to, if you have a cervix left behind, well, there is that possibility, though small, that you might have bleeding when you give cyclic hormones. Of course, it's not hard to figure out if someone has a cervix. Not hard for me. I can just do an exam. I'll find out in 5 seconds. But not everybody does exams. So there you go. If you're doing telemedicine, you're not doing an exam. So I don't believe in that gynecologists should only do telemedicine. But that's my bias. I think physical exams are still really important. Plus, how are you going to check a lot of things if you can't do an exam? But that said, we'll leave that aside for the moment. Okay, so if a woman has a hysterectomy, she doesn't have her cervix, we'll say a total hysterectomy, she doesn't have her cervix or her uterus. Well, if she still has her ovaries and she is premenopausal, what does that do to the ovaries? Well, clearly you're not going to have bleeding, so you can't say, well, the period's gone, so you're in menopause. No, because menopause is really about the ovaries, not about the uterus. That's why I keep saying it's not about the uterus, it's about the ovaries. Even women who have a hysterectomy will have ovarian aging and go through menopause. Well, if you have a hysterectomy prior to menopause, what happens to the ovaries? Well, they don't fare as well because you lose about 10% of the blood supply to the ovaries when you take out the uterus. The majority, like 90% of the blood supply to the ovaries, comes from the pelvic sidewall, from the ovarian artery, comes from the side. But 10% comes from the center and then out from where the uterus is. So when you cut out the uterus, you cut the vascular supply. So the ovaries will have a reduced supply of blood, a reduced supply of oxygen and nutrients, and they tend to go into an earlier menopause, typically by about a year, which actually is not insignificant, but of course it could even be earlier. So ovarian preservation is really important, but when you do a hysterectomy, it can cause ovarian aging at a more rapid rate and earlier onset of menopause. Now, how are you going to know if you go into menopause if you have no uterus and you can't see what happens to your cycles? Okay, the same can actually happen if you've had an endometrial ablation where the uterine lining is essentially burnt out and there's no bleeding. Some have a little bleeding after an ablation, some have zero bleeding. Well, if you have no uterus to bleed or you have no uterine lining to bleed, then what are you going to do to measure? Blood tests. Okay, so you can't know exactly when you're going through perimenopause. Even with the uterus, there's no exact sign of when you're going through. But here's what I do, okay? This is what I do to figure it out. Well, first of all, if someone's having symptoms, I will definitely work up symptoms. I have to do a rule out, make sure it's not a thyroid problem or an infectious problem, anything else, okay? So I want to make sure that we don't have some other underlying cause of her symptoms, because there's so many symptoms that are related to perimenopause. Next, I would get an FSH level. Now, I can't time it. I can't say a day 3 FSH, day 3 being the third day of the menstrual cycle. So I have to do a random one, okay? But if the FSH is over 20 something, or it's like in the 20s or higher, that is a very high medical probability that the woman is in perimenopause, okay? Because the FSH is elevated. You would certainly want to get more than one level because it's always possible that you happen to do it just prior to ovulation when there's a little bit of a surge in FSH. Okay, I would also get an estrogen level. If you get estrogen levels multiple times during a cycle, not like every day, but maybe once a week, and you see what's happening to the estrogen, it will tell you also, because a normal menstrual cycle has a certain rhythm of estrogen, you'll see if that's happening. You can also go by age, okay? The normal, so-called normal age for menopause defined as 12 consecutive months without any period, is 45 to 55, late menopause over 55, early menopause 40 up to 45, and premature below the age of 40. So if you have a woman that is in the 45 to 55 range, guaranteed she is perimenopausal, okay? Because think of perimenopause as the decade preceding the final year of no periods, okay? So she's perimenopausal. If she is in the 40s, like say she's 40 to 45, there is a high probability that she is perimenopausal, and she could even be perimenopausal if she is in her late 30s, okay? So then you go by signs and symptoms. You can get those few blood tests. You can get an anti-Mullerian hormone, which tells you something about egg reserve. And if the number is very low, especially below a 1, then clearly she has very little egg reserve. So there's a variety of ways that we can tell. What's the danger of starting hormone supplementation too early? Well, you might create breast tenderness, not dangerous, but could be annoying. You might have some irregular bleeding, not likely, but possible, not dangerous, but could be annoying. You might have some fluid retention from estrogen, not dangerous, but could be annoying. So there's nothing dangerous. Remember, this is an age group when women are often put on oral contraceptives, which are way, way more like risky than putting people on bioidentical, human molecular identical hormones, identical to what the ovaries make. And you don't give a lot. I call it a safety net. You're just giving like a buffer zone so they won't fall below that. What happens in the perimenopause? A lot of bad things. The vascular system starts to age, plaque develops, the arteries get more unhealthy, the intima starts becoming unhealthy. That's the lining of the arteries. You lose significant bone. Sleep is disturbed, mood disturbances. Often there's vaginal dryness, sexual disturbances. Joints can change, joint achiness. You start getting less laxity, or you like less flexibility of your ligaments and tendons. So a lot of things are happening long years before the actual final menstrual cycle, because that's an end stage, a late stage of the process of ovarian aging. There is no danger in starting hormone supplementation a little early. There's just annoyance that could happen, no danger. So I say, when in doubt, give some. You don't give a full hormone therapeutic dose, you give a light dose. It's just like a safety net, so you can't fall below that. Also, not proven, but possibly it'll help to dampen the big swings of hormones that women often have in the perimenopause by maintaining the brain sensors showing that there's at least a reasonable amount of estrogen, so you don't have those big swings that are triggered by the brain sensing too little, too much, too little, too much, and you're on the wild roller coaster. So you may help dampen that roller coaster a bit. And women will see how they feel. This is an area where clinical judgment and clinical response really matters. But not having fear of these hormones, these human identical hormones, and recognizing they're like enormously safer, very safe compared to using oral contraceptives in that age group. So if in doubt, I say try some. You can always change your mind, you can always stop it, and you then cycle the hormones along with the cycle. So you would go ahead and give, if you're having, obviously we're talking about someone with a uterus. What if you don't have a uterus? They're more challenging, okay? So you might want to get estrogen levels, whether with urine metabolic byproducts or getting blood tests through a cycle, to try to see where is the cycle, so you can sort of get a better timing if you're going to add progesterone. Or in the early stages when you don't have a uterus, just give estradiol and just do a couple of times a cycle to see if there's a progesterone level that's consistent with ovulation. By using blood tests and sometimes urine metabolites of these hormones, you can follow what's happening even without a uterus to have an idea of if they're still ovulating, if they're making progesterone, how the levels are doing, if they're rising adequately. Labs are our best friends. They can really help when we don't have a uterus to guide us with what's happening with the cycles. So we look at symptoms, we look at the age, we look at medical probabilities, and we do lab testing to get an idea of when we should start hormones and how we should give them. Now, what if we have a woman not perimenopause? She's full-blown menopause. Her FSH levels are sky high. Her estradiol levels are way low in the menopausal range. And we've established she doesn't have a uterus. She doesn't have a cervix. Plus or minus, for the moment, the ovaries. We'll let them be on the back burner for the moment. Those women need to go on hormone therapy, in my opinion, because menopause is a state of hormone deficiency. I think that's now being widely accepted. I've talked about that forever. If you have a missing hormone, you replace the hormone, and you try to replace it to levels that are consistent with what people have when they're optimally healthy. It's like so simple, okay? Women are complex. I can't help it. That's how we are. We are complex. So we have progesterone too, not just estrogen, and our hormone levels are very variable. They're not like a man that has minimal fluctuations of testosterone. We have big fluctuations in our hormones. We're not going to mimic exactly, not yet anyway, a menstrual cycle, but we're going to come somewhat in that ballpark by giving progesterone in a pulsed way. We don't have to worry about bleeding when women have had a hysterectomy, so that actually makes it kind of easy, but we don't have the period to use as a marker either to help us, to guide us. So we have to work other ways, how people feel, and using lab testing. So we would, if a woman though has no uterus and no hormones being produced by her ovaries, we're talking about estrogen, estradiol, and progesterone, not talking about testosterone yet, okay? Then we're going to give a physiologic dose of estradiol just like we would if a woman had a uterus, because this is menopause. The ovaries are not producing those hormones. We're going to replace those hormones, and we're going to replace the estradiol through the skin, transdermal, by patch, gel, or compounded cream to achieve levels that are consistent with a healthy reproductive age woman. We want them to be preferably at least in the 60s, heading closer to 100, or up in the early 100s is fine. I would say somewhere between 60 and 150. These are general numbers, and that is measuring in picograms per mil. Okay, now I'm also toying with the idea, but we'll go into that another day, of having different levels of estradiol, a different level that's higher when the progesterone is being given. And I'll talk about that another day because it's something I'm still really working on. I'm trying to get some studies going, but I'll tell you more about that. I think I've touched on it before, but we'll definitely come back to that. But right now, let's talk about what is more standard in what I do. Okay, remember, everything I'm telling you is what I do. Okay, I'm not saying everybody else does this too. So you give the estrogen through the skin in whatever form the patient wants and can afford, and you feel comfortable with. And even though the woman doesn't have a uterus, she should get progesterone. Now, the conventional world, for reasons that don't make sense from a medical or scientific perspective, say if you don't have a uterus, you don't need progesterone. Well, that's really absurd because the progesterone that women make, just like the estrogen, the estradiol that women make, doesn't work only on the uterus, okay? There are receptors for progesterone in many, many organ systems of the body, and progesterone has a diverse group of processes that it's involved with, benefits throughout the body, and progesterone works in a beautiful, synergy with estradiol, turning on and off genes, gene expression, up and down regulating receptor function. So when you have estradiol upregulates its own receptors, progesterone receptors, thyroid receptors, testosterone receptors, meaning the receptors work better. Progesterone downregulates estrogen receptors, particularly the alpha receptor. That's the one that is causing growth factors, proliferation. So it downregulates that. The purpose, of course, in the uterus is to stop the growth of the uterine lining. Now you may say, but there's no uterus. What do you care about the uterine lining? There's no uterus. But this works differently in terms of stopping proliferation and growth in other organs. I mean, the same effect, but it has, in terms of what it does on the receptor, but it has different effects in terms of the benefits in different organs, because you don't want consistent proliferation. You don't want to have endless growth. You want to have some breaks. This is like the way that the body has brakes put on growth. Progesterone also downregulates testosterone receptors. So there's this beautiful balance between these hormones. Progesterone is very anti-inflammatory, works on the immune system. Progesterone helps improve bone health. Progesterone actually increases vascular health by also increasing nitric oxide production. It helps create and maintain the myelin sheath. That's the insulation of nerves. It's neuroprotective. Its metabolites, like allopregnanolone, when you have proper amounts, is neuroprotective. It's an anti-anxiety, it's an antidepressant, and it helps promote calmness by activating the GABA A receptor. So there's so many benefits of progesterone. It's not just about having periods. But you don't want to give progesterone every day. That's not how it works. You don't want to downregulate the receptors of those hormones all the time. You want to do it the way nature intended. Let's not try to outsmart Mother Nature on this one. The biggest failed experiment of trying to outsmart Mother Nature has been ultra-processed food, which has been a big failure. So don't think we're smarter than nature in terms of creating the rhythms and levels of hormones. Let's try to recreate to some degree the hormone levels and rhythms of a healthy 20-something-year-old, like a 22-year-old, 23-year-old. Those are the days when women are the healthiest and most fertile, and that's what we want. We're not going to have fertility. We want the health part, okay? That's why we want the hormones, so that we can have healthy longevity. So women with a uterus should have progesterone. Women without a uterus should still have progesterone for 14 days a month, in my opinion. If you know anything about these hormones, how they really work in the body, then why would you not want it? It's the yin to the yang. You want to have that balance. You don't want estrogen only. This is really important. Nature gave us these hormones to give us balance. There's another whole system called the endocannabinoid system. We'll talk about that another day. Estradiol increases the production of the endocannabinoids. Okay, when you have high levels of endocannabinoids, they downregulate the production of estrogen. Progesterone also has impact. Okay, so progesterone is like, it has the opposite effect on the endocannabinoid system. It suppresses it. So estrogen in general increases the production of the endocannabinoid system. The endocannabinoids, when they're high, has a feedback system to lower the production of estrogen. So there's this beautiful balance. Progesterone lowers the production of endocannabinoids. And this matters because this has to do with regulation of all the organ systems in the body. This is how things are mediated. And you need to have this beautiful balance between the hormones. Progesterone isn't just about the uterus. If you don't have a uterus, you still should have progesterone. And I wish that would become mainstream. I'm really working on it. Just think about it. How logical is it to not have the balance of the hormones just because you don't have a uterus? It is illogical. Okay, so a uterus is also an interesting organ. I'm just going to mention this. There's been some data, this is not proven, that if you take out the uterus, now sometimes you have to take out the uterus, but we want to try as much as we can to conserve organs. Now, I try to conserve organs, and I don't recommend hysterectomies lightly, but I have to say sometimes a hysterectomy is the best course of action because that's just how it is. You know, you have to go risk-benefit ratio for everything. But you don't want to take it out for no good reason. Okay, just like we never want to take out the ovaries for no good reason, because now we know ovaries, by the way, continue to produce testosterone forever. That's why at least till age 65, if you should leave the ovaries in unless there's a problem with them, a real disease of the ovaries, because you actually accelerate morbidity and mortality if the ovaries are removed before the age of 65. I don't know how much good data there is after age 65, but usually by age 65, the ovaries are so shrunken and so tiny, it's probably not a big deal. Also, once again, this is the data based on no hormone replacement therapy. So if you replace the hormone, probably the data is not going to be the same. So what hormone? I already mentioned it. It's testosterone. So you don't need a single egg to make testosterone. Different skill set. The ovaries make testosterone indefinitely. Well, what happens if you have a hysterectomy? What do you lose as part of the testosterone? If the ovaries are left behind, probably minimal or none. In no way is the testosterone affected. We actually don't know the answer. We know that the ovaries age more rapidly if the uterus is removed because of the blood supply being altered. We just don't really know about testosterone. Maybe it does decline a little. We just don't know. But I think it should be followed. Any woman who's had a hysterectomy may have a higher rate of loss of testosterone production. We just don't know. Where does testosterone come from in the female body? Well, approximately 25% comes from the ovaries and 25% from the adrenal gland. Most of the remaining 50% comes from adrenal androgen precursors to testosterone, and the androgen precursors like DHAS, DHEA get converted into testosterone in peripheral tissues like the fat tissue. That's not 100% of the remaining 50%, but it's the majority. So close to 75% of all the testosterone in a normal reproductive age woman comes from the adrenal gland. But there are no sensors in the brain to testosterone levels. So when the ovaries are removed and they no longer make the 25% of the testosterone for the female body, the adrenals do not pick up the slack. They do not. And with aging, the portion of the adrenal gland that makes testosterone, called the zona reticularis, tends to shrivel. So over time, the adrenal gland tends to produce fewer androgens anyway. So if a woman has her ovaries out, she 100% needs testosterone. 100% of the time. She's just lost 25% of her testosterone production. So every woman who's had her ovaries out needs testosterone. I don't think that's very debatable, okay? So back in the day when they were almost getting an approval for testosterone patches, that was the main indication for women who'd had their ovaries removed, because they always need to have testosterone supplemented. So no ovaries, oophorectomy, testosterone. But women can lose testosterone just with aging also from the adrenal gland, as it makes less and less as you age in general. No exact timeline. So it's perfectly reasonable to supplement with testosterone. And we'll talk more about testosterone in another program, but I just want you to know, no ovaries, you need testosterone, okay? So no uterus, the ovaries will age more rapidly. No uterus and you're in menopause, you need to give hormones, and you give them just like you would give them if you have a uterus. You give both estradiol and you give progesterone in a cyclic manner, even though you're not going to bleed when you don't have a uterus, because you want the hormones. You're not giving them for the uterus. You're giving them for the body. Okay? So you need to have these hormones. You need to have them at reasonably physiologic levels, and you need to give them cyclically for optimal health. If you have a uterus, of course, you also need to give the progesterone so that you have an appropriate pretend period, but real blood. Okay, but it's not just for that. It's for all the functions that progesterone has in the body. And we'll talk more about progesterone. I love progesterone. So I hope you now feel clear on what a total hysterectomy is, a partial or subtotal hysterectomy, a total hysterectomy with bilateral salpingo-oophorectomy, what happens when you don't have ovaries, what happens when you have a hysterectomy to the ovaries, how to have hormones in menopause and perimenopause with or without a uterus. It's a big story, and I want you to get it so that you can try to find what's best for you.